I think that boring cases or routine cases are really important throughout the day because it gives you sort of a sense of trying to perfect routine cataract surgery as much as possible. And so this is sort of one of those cases. A patient has moderate stage cataract, probably about a 2 plus nuclear sclerosis. Um, and the goal for this surgery is to give the patient the best possible visual outcome. And so in this case, I make a standard side port incision, and then I use a viscoelastic cannula in order to make my main wound. And I do use a cystotome to start out my capsulorhexis. Um, I feel like it's a little bit more predictable than just going straight in with a Utrata, but I think doing a Utrata alone is an excellent technique as well. I like to center the capsulorhexis as much as possible, not for the patient's pupil dilation, but more towards the reflection of the light. And so in this case, I feel like I was able to do that reasonably well. And, for hydrodissection, I always try to get two good waves. Even if I see a good amount of rotation with one wave, I always like to try to get two just to really free up the lens really well. And the reason for that is I actually like to use a pre-chopper in order to break up the lens into four quadrants. I feel like reducing the amount of phacoemulsification energy, but also the amount of fluid that's flushing into the eye is really useful to give patients a good outcome. And so using a pre-chopper does a lot of the work of breaking up the lens for me, so that now I'm just using uh, a standard quad maneuver with the phacoemulsification machine to just eat up the lens. And again, this uses less fluid that's flowing through the eye because I'm not having to sculpt or chop or do anything like that. But then it also uses very low CDE. This case is, I think, around 1 CDE for the entirety of the case. And so I really like using the pre-chopper for routine cataract surgeries. I don't think it's great in cases where you suspect that there's annulopathy, but I think for routine cataract surgery, it's a really useful tool. And so, the lens is out, and now I'm moving on to cortical removal. I usually try to get the subincisional cortex first. I feel like uh, you have sort of the stability of uh, the rest of the cortex when you're getting, in my opinion, the hardest part of the cortex, which is subincisional. And then I do like to do a pretty aggressive cleanup of the posterior capsule just to give patients the best possible outcome. So you can see that I'm doing a fairly brisk cleanup of the posterior capsule. I like to clean the capsule with um, the INA instrument, and I think it does really well to clean the cortex. I usually do circular sweeps, as you saw there, and I think that helps to give prevent the capsule from rupturing during the polishing. This lens is a Clarion lens to give the patient a good distance visual acuity. He understood that he needed to wear glasses for up close. And then I just centered the lens. I always like to put the lens in a 12-6 position because whenever possible, I like to do a little cleanup behind the lens for the final INA, as you can see here. This was a good case. It's sort of having a few routine cases throughout the day really helps to, boost morale and, hopefully give patients the best possible outcome. Thanks for watching.